If you're over 60 and you've noticed your thinking feels a little slower, your words take a beat longer to find, or your legs feel weaker climbing the same stairs you used to take without thinking, you may have quietly written it off as normal aging. But for millions of people taking a cholesterol-lowering statin, some of that fog and some of that weakness has another possible explanation. And it's one that almost never comes up in a routine 7-minute doctor's visit. Statins are among the most prescribed drugs in the world. They've saved an enormous number of lives by lowering LDL cholesterol and reducing heart attack risk. That much is not in question. What is in question, and what a growing number of geriatric specialists are now raising, is whether the same dose that made sense at 50 still makes sense at 70 or 80 or 85. The body processes these drugs differently as it ages, and the risks and benefits don't stay fixed over a lifetime. Today, I'm going to walk you through what the research actually says about statins and the aging brain and body, the cognitive fog some patients report, the muscle changes, the depletion of a compound called CoQ10, and why so many doctors now talk about a specific age where the whole calculation shifts. This is not a video telling you to stop a medication your doctor prescribed. It's the conversation that conversation is often missing, so you can walk into your next appointment and actually have it. To understand why age changes the equation, you first need to understand what a statin actually does inside your body. Statins work by blocking an enzyme in your liver called HMG-CoA reductase. Think of this enzyme as a factory foreman on the production line that manufactures cholesterol. Statins tell that foreman to slow the line down, so your liver makes less cholesterol and pulls more of it out of your bloodstream. That's genuinely useful. Lower LDL cholesterol means less buildup in your arteries, which means a lower chance of the plaque ruptures that cause heart attacks and strokes. But here's the part that gets left out. That same enzyme, the one statins block, doesn't just make cholesterol. It sits on a manufacturing pathway that also produces a molecule called coenzyme Q10, or CoQ10, a compound your cells need to generate energy. In a younger body, this trade-off is usually well tolerated. Cells have reserves. Muscles regenerate quickly. The brain has plenty of metabolic headroom to absorb small disruptions. In an older body, those reserves are thinner to begin with. Muscle mass has already been declining since your 40s, a process called sarcopenia. Mitochondria, the energy factories inside your cells, are already less efficient. So a side effect that a 45-year-old shrugs off might land very differently on a 78-year-old. So the question is, does this mean statins become dangerous with age? Not exactly. It means the margin for error gets smaller, and the conversation about dose, necessity, and monitoring needs to happen more carefully. Let's look at what the actual research shows. Let's start with CoQ10, because it's the thread that connects almost everything else in this video. CoQ10 lives inside your mitochondria, and it plays a critical role in the electron transport chain, the process your cells use to convert food into usable energy in the form of a molecule called ATP. Think of CoQ10 as a rechargeable battery pack sitting inside every one of your cells' power plants. Without enough of it, the power plant can still run, but at reduced output. Muscle cells and heart cells are especially rich in mitochondria because they demand so much energy. That's exactly why they're also the tissues most sensitive to CoQ10 depletion. A study published in the American Journal of Cardiology followed patients on statin therapy and found that plasma CoQ10 levels dropped by an average of 40% within just weeks of starting treatment. Other clinical research has linked lower circulating CoQ10 to the muscle pain and weakness some statin users report, though not every study agrees on how strong that link is. This remains an active area of research. Now, what does lower cellular energy output actually feel like in daily life? In muscle, it can show up as fatigue, cramping, or a feeling of heaviness in the legs, sometimes dismissed as simply getting older. In more significant cases, it's associated with a condition called statin-associated muscle symptoms, which researchers estimate affects somewhere between 5% and 20% of statin users, depending on the study and how symptoms are measured. Over time, and combined with reduced activity because muscles feel weak, this can contribute to sarcopenia, the age-related loss of muscle mass and strength that is one of the strongest predictors of frailty, falls, and loss of independence in older adults. Now let's talk about the brain, because this is the part that generates the most debate among researchers. Your brain is roughly 2% of your body weight, but consumes about 20% of your body's total energy. It is, in other words, one of the most energy-hungry organs you have, which makes it plausible that anything affecting cellular energy production could touch cognition. The FDA added a warning label to statins in 2012 after receiving reports of memory loss and confusion in some patients, describing these effects as generally reversible after stopping the drug. At the same time, several large studies, including a meta-analysis covering hundreds of thousands of patients, found no significant overall increase in dementia risk among statin users, and some studies even suggested a possible protective association. So what's the honest picture? The research is genuinely mixed. Some patients report real noticeable brain fog that improves when their dose is adjusted or the medication is changed. Population-level studies, looking at hundreds of thousands of people, mostly don't show statins causing dementia. Both of those things can be true at once, an individual sensitivity that doesn't show up as a signal in a huge data set. This is exactly the kind of nuance that gets lost when a headline just says, "A drug is destroying your brain." And it's exactly why this needs to be a personalized conversation with your own doctor rather than a blanket rule. And this is where the question of age comes in specifically. So if you're 60, 70, or beyond, and you're on a statin, here is what actually matters. 5 things worth understanding, and, where relevant, raising with your doctor. This is not a prescription to stop anything. It's a framework for an informed conversation. First, understand the difference between primary and secondary prevention. If you're taking a statin because you've already had a heart attack, a stroke, or you have diagnosed coronary artery disease, that's called secondary prevention, and the evidence for continued benefit, even into your 80s, remains strong. If you're taking a statin purely because your cholesterol number was elevated and you've never had a cardiac event, that's primary prevention, and the calculus is genuinely different, especially past 75. Second, ask about the 90-day trial. Some physicians, when a patient reports new muscle weakness or cognitive fog after starting or increasing a statin, will pause the medication for a defined window, often 4 to 12 weeks, to see if symptoms improve. This isn't self-directed stopping. It's a monitored trial done with your doctor tracking your cholesterol and cardiac risk the entire time. Third, ask whether CoQ10 supplementation makes sense for you. The typical studied range is 100 to 200 milligrams per day, usually in the ubiquinol form, which is more readily absorbed in older adults whose conversion of the ubiquinone form declines with age. The evidence on whether this reliably prevents muscle symptoms is mixed, but it's a low-risk conversation to have, particularly if you're already experiencing fatigue or weakness. Fourth, ask about statin type and dose, not just whether to take one. Some statins, like pravastatin and rosuvastatin, are less fat-soluble and cross into brain tissue and muscle less readily than others, like simvastatin or atorvastatin at high doses. Switching type or lowering dose rather than stopping altogether resolves symptoms for a meaningful number of patients. Fifth, Understand the concept of deep prescribing. This is a formal, structured process, usually guided by tools like the start criteria used in geriatric medicine, where a doctor reviews every medication an older patient takes and asks whether the original reason for starting it still applies, given current life expectancy, frailty, and quality of life. Statins are one of the medications most commonly reviewed in this process for patients over 75 to 80, particularly those with limited life expectancy or significant frailty, where the years needed to see cardiovascular benefit may exceed the years of expected benefit remaining. So, to summarize the stack, know which category of prevention you're in, know that any pause should be doctor-supervised, know that CoQ10 is worth a conversation, know that switching statins is often overlooked, and know that deep prescribing is a real, structured clinical process, not something you do alone on a Tuesday afternoon after watching a video. Now let's cover the mistakes that make this situation worse, because there are real ones on both sides of this issue. The first mistake is stopping a statin abruptly without medical supervision, especially after a heart attack or a stroke. Studies on statin discontinuation after a cardiac event have found a meaningfully higher rate of subsequent cardiovascular events in patients who stopped versus those who continued, even accounting for other health differences. The fix is simple. Any change to dose or discontinuation happens with your prescribing physician, ideally with a clear plan for monitoring what happens next. The second mistake is assuming every new symptom after 60 is the statin's fault. Age-related muscle loss, thyroid changes, vitamin D deficiency, and dozens of other common conditions in older adults can produce nearly identical symptoms: fatigue, weakness, and mental fog. Blaming the statin without ruling these out can mean missing the actual cause. The fix is asking your doctor for basic blood work, including thyroid function and vitamin D, alongside any statin conversation. The third mistake is taking CoQ10 in the wrong form or at too low a dose to matter. Cheap ubiquinone form supplements are poorly absorbed, and doses under 100 milligrams are unlikely to meaningfully raise blood levels in an older adult. The fix is looking specifically for ubiquinol on the label and dosing in the 100 to 200 milligram range if your doctor agrees it's appropriate for you. The fourth mistake is treating this as a one-time decision instead of an ongoing review. Your risk profile at 65 is not your risk profile at 80. What made sense 5 years ago deserves revisiting, particularly after any major change in health status, mobility, or diagnosis. The fix is bringing this up at your annual physical every year, not just once. If you do have this conversation with your doctor and something changes, whether that's a dose adjustment, a switch in statin type, or adding CoQ10, here's roughly what to expect. Within the first 2 to 4 weeks of any change, most patients who are going to notice a difference in muscle symptoms begin to notice it, whether that's less soreness or more stable energy during activity. Within 4 to 12 weeks, if cognitive fog was genuinely related to the medication rather than another cause, patients typically report it lifting or becoming meaningfully less pronounced. This is also the window your doctor will likely use to reassess cholesterol levels if any dose change was made. Within 3 to 6 months, if CoQ10 supplementation was added, blood levels typically stabilize at their new, higher baseline, and any associated improvement in energy tends to be at its most consistent. Throughout all of this, your doctor should be tracking your cholesterol panel and overall cardiovascular risk, not just how you're feeling day to day. Feeling better and staying protected are both the goal, not one at the expense of the other. A few practical things that make this conversation and this process easier. Keep a simple symptom log for 2 weeks before your appointment. Note energy levels, any muscle soreness, and mental clarity on a basic 1 to 5 scale each day. Doctors respond far better to a pattern written down than to a vague memory of, "I've been feeling off lately." Bring your full medication list, including over-the-counter supplements, to every review. Grapefruit juice, certain antibiotics, and several common supplements can interact with statin metabolism, and this sometimes explains new symptoms that have nothing to do with the statin dose itself. Ask your doctor directly. Given my age and health history, am I primary or secondary prevention, and does that change your thinking? This single question tends to unlock a much more specific, personalized answer than a general question about side effects. If muscle weakness is a concern, pair any medication conversation with resistance training. Even light resistance exercise 2 to 3 times a week has been shown to help preserve muscle mass in older adults, independent of medication status, and it directly counters the sarcopenia trend that makes statin-related muscle symptoms feel worse. Track objective markers over time, not just how you feel. Grip strength, measured with an inexpensive hand dynamometer, and the time it takes to rise from a chair 5 times in a row are both simple, validated measures geriatricians use to track functional decline. And both are things you can measure at home and bring to your appointment. Here's the core of it. Statins work by slowing down a pathway that makes both cholesterol and a compound called CoQ10 that your cells use for energy. And as the body ages, it has less room to absorb that trade-off without noticing it in muscles and, for some people, in mental clarity. The actionable takeaway isn't to stop anything on your own. It's to walk into your next appointment with specific questions. Which category of prevention you're in, whether CoQ10 is worth discussing, whether a different statin or dose might serve you just as well with fewer side effects, and whether a formal medication review makes sense given where you are now. This is entirely within your control. You don't need to choose between protecting your heart and protecting how you feel day to day. With the right conversation, most people find they can have both.